So I want to start with just a quick story. Hopefully I'll finish early, so we won't be late for this session. But story I don't know if I've ever told before, and it involves Herb Reynolds, actually. He's never heard this story. But 29 years ago, I was applying for pulmonary programs, and I came to Yale. And I actually had a bad day there because not Dr. Reynolds, but someone else in his faculty took a personal call while I was interviewing them and was delayed like an hour, and I got thrown off whack there. But Dr. Reynolds was intimidating to me then, and he still is now. And so it's interesting because I was a lot of the posters I selected were very similar to his. In fact, if you realize that a few of the ones he presented were not sarcoid posters, a lot of them were. So I feel justified or validated. But anyway, one of the things I said at my last brief talk this morning was that really a major reason why we're here is because of the patients. And several of us here are clinicians and see a lot of sarcoidosis patients. And I don't hardly go a day in my clinic where at the end of the clinic, before the patient's leaving, we've all heard this. They say, "Doc, what are we doing? What are we doing to cure this thing? Is people working to cure this thing?" And my standard answer to that is, well, we're doing a lot to try to cure this thing, and there are a lot of people brighter than me who are working on it. And when I say that, the main group of people I'm talking about is you. I'm talking about WASOG, and I'm talking about what we're doing. So what I'm going to try to do is, at first I'm going to be kind of rambling, and I'm going to maybe focus in on something at the end. So I just want to start by kind of rambling and talk about some of the posters that I saw and how they may possibly impact sarcoidosis and thoughts about the future. There were 4 posters that dealt with something which I think we've kind of got our handle around a little bit. Actually, the first infliximab study, the large study, maybe suggested this, but stage 4 pulmonary sarcoidosis is not necessarily burnout disease. In fact, a lot of the most active pulmonary sarcoidosis is in these group of patients, and these were 4 studies looking at PET scans that all really showed the same thing, that a lot of these patients have active PET scans. And of course, Carol Johns noted this many, many years ago in the cohort she followed for a long time, that about half the patients with stage 4 disease required therapy or the disease would progress. So I thought that was kind of modern confirmation of that. I was also intrigued by this poster that Dr. Reynolds alluded to, that a Treg marker was increased in mediastinal lymph nodes more than in peripheral blood and BAL, and it suggests that, you know, maybe we should be looking at more than 2 compartments. Maybe there's a blood compartment and a BAL/lung compartment. Maybe there's a lymph node compartment, and that's something really I don't think has been addressed in sarcoidosis. And again, looking in the future, this is something we might want to look into, that there are more than the target organ and the blood compartment. There was some intriguing work looking at the role of mycobacteria and MCAT-G. Of course, there's a lot of work that's been done on that in sarcoidosis. I thought this was a good poster. I was, like Dr. Reynolds, very intrigued by the FAST poster in BAL, looking at a plausible mechanism for smoking being protective of granuloma formation in sarcoidosis. There was a very well done paper about upregulation of IL-23, which I think, IL-23R, which I think is, could possibly be an important mediator in sarcoidosis, which is being evaluated in a clinical trial. This I thought was somewhat interesting, and it actually related to another poster that these investigators found that MTB heat shock protein was elevated in TB patients, no surprise, but it was elevated to a much greater degree in sarcoidosis. And then I'll get into another poster that this group discussed to try to explain this. And again, I'm repeating what Dr. Reynolds again. See, we picked similar posters. The one from the Nashville group, Wonder Drake and Oswald Richter, showing that this PD-1, which I don't know what it is, but it's expressed in CD8 cells, and this can be caused by increased antigen stimulation leading to T cell exhaustion. Again, with this, the reason this intrigued me was I think this is a relatively new concept in sarcoid, that not only an antigen may be important in sarcoidosis, but it's the persistence of an antigen. It may be that the antigen is present for a long, long time. And this may relate to some of the recent work done by Dr. Moeller and Chen with an amyloid protein causing an antigen to be exposed for a prolonged period of time. And that just the prolonged period of exposure may be part of the process in developing sarcoidosis. So that's some of the intriguing things that I gleaned from the posters, which I think may have important implications in the future. In going through the sessions, there was a lot of intriguing information. The quality of life session I thought was a very good one, where the just assessment of quality of life in sarcoidosis was addressed, which is a very tough issue. It looks like, at least in the presentations from Maastricht, that a lot of the cognitive impairment appears not to maybe be real, that the patients feel that they're cognitively impaired, but a lot of, actually when you do some testing, they may not be, but a lot of this may relate to fatigue or depression. There's a lot of discussion about measurement of fatigue, and Dr. Lauer coined this term, sarcoid brain, which is interesting, where the problems in sarcoidosis patients may not be strictly due to fatigue, but may be due to a lot of other associated problems which impact cognition in sarcoid. There was a very elegant discussion by the Maastricht group, who have been the major people in the forefront of small fiber neuropathy and sarcoidosis, and there was discussion about measurement and some very intriguing and promising discussions about treatment of that disorder. Just some personal thoughts about this is that I mentioned this as a question, but I show it now. I think one of the things we need to do is, when we look at quality of life measures and depression and anxiety, that's a little bit distant from sarcoidosis. It's probably related to sarcoidosis, but I think it would be important to ferret out what portion of that is due to chronic disease and what portion of that is due to actually sarcoid per se. And the example I give is someone who has skin lesions which cause psychosocial embarrassment. I call this stigma, and that may lead to depression and anxiety. And we may need to measure this, because if we just look at depression and anxiety, we may be one step removed from what the sarcoid itself is directly doing to cause the depression and anxiety. In terms of sarcoidosis brain, it'll be interesting to see if this really is real. Cognitive impairment is questionable. It's now questioned that it really exists by the Maastricht group. This will be, I think, an interesting area to explore in the future. In terms of outcome measures, we just had a very interesting session, very short, but I think enough to just intrigue us and to make us realize that there's more work to be done here. Very important work, because if we're really going to solve these sarcoidosis problems, we're going to have to be very clear and precise about what we're measuring. So I think that brief session got us in focus and got us to think about this very important clinical problem. So I'm now going to focus on something which I think is the 10,000-pound gorilla in the room that we all try to avoid, which is, what is the cause of sarcoidosis? And this was a paraphrase of the access hypothesis, which I think most of us, or all of us, would agree with, which is that sarcoidosis is a granulomatous inflammatory response resulting from environmental and/or occupational exposures, and you include infection into environmental, in genetically susceptible individuals. And we had a whole session, or the first session, about a lot with etiology, and there was a very nice talk by Joachim Müller-Kornheim about genetics, and he discussed GWAS and other genetic analyses, and in some elegant work that he did, found that there was a disorder of carbohydrate metabolism, which seemed to be involved with presenting HLA presentation of peptides to the T cell receptor that may be very important. He also noted that certain gene categories or gene profiles of immune response were associated with fibrotic sarcoidosis. In terms of prognosis, there's a need to relate genotype to phenotype, and his group has done work in the past about developing a phenotypic description of the disease, so it seems to correlate with some inflammatory mediators. I throw this out as a question, is somewhat argumentative and controversial, and just don't throw anything at me, but this may stimulate a response from people in this area, which is I don't have high hopes for genetics as leading us very far in and of itself to finding the cause of sarcoidosis. And I'm using quotes here in that talk by Joachim, where he said that this is a brute force maneuver that involves multiple comparisons, and because of that, the odds ratios are extremely low. And then if we throw on top of that, if we all believe that there is an interaction between genetics and an environmental exposure, we now have to take not only the genetics, and we're already at requiring a very high end with low odds ratios, and then we have to pair that with maybe multiple exposures. I don't know if we have enough sarcoidosis patients, quite frankly, to yield an obvious result. And the other problem with this approach in and of itself, just doing genetics in isolation to try to find the cause of sarcoidosis, and again, this is a quote from Joachim, it's that this method turns hypothesis testing upside down. I mean, at the end, we found out that there's a disorder in carbohydrate metabolism. Well, how much closer does that get us? I kind of think back to a British tongue-in-cheek comedy, The Hitchhiker's Guide to the Galaxy, if anyone knows that, where the answer to the universe is 17. But what's the question? So it's the same sort of thing here, which I think is a potential problem. And he stressed, I think it's going to be very important for us to develop a good phenotypic model to divide the phenotypes appropriately. And I think that the Prof. Müller-Kornheim approach is a good start, but I think we need to go further with it. I do think genetics is extremely important. I think Ron Dubois in his talk made that clear, and others have at this meeting, that I think Gruder's group in Sweden, that I think genetics is useful actually right now in many ways in terms of prognosis and treatment. So I want to make that clear, but I still question how far we're going to go alone with genetics in getting to the cause. It's a question. Wonder Drake gave us a talk about infectious causes, potentially, mycobacteria that seem to be distinct from MTB and M. bovis. And she's identified proteins and DNA and T-cell responses to these proteins and antigens that seem to be present when mycobacteria are in logarithmic growth, which is very intriguing. You know, the issue always is, and I'm not the first one, I'm not the 100th one to say this, the problem I have with this is that, then why do steroids and anti-TNF and other immunosuppressant agents work in sarcoidosis if this is a classic infection? Of course, it could be a host response to an infectious antigen, like in some cases of HP or ABPA, so maybe we don't need live antigen. But still, there are questions of what about patients who seem to have, at least we believe, pure occupational exposures? How does this tie into the infection model as the all-encompassing model? I really think that's going to be difficult. Lee Newman gave a very intriguing talk, which I think is getting at where I'm going with this, which is he tried to give, to borrow from Einstein, kind of a unified theory, trying to tie things together when he talked about particulate exposure, but didn't try to come up with an explanation for all of sarcoidosis, but rather to put it in a place in a process leading to sarcoidosis when he talked about particulate exposure functioning as an adjuvant, basically causing the immune system to be kind of bristling with potential to form granulomas to any infection that then came by, which I think was a really innovative, interesting thought, so that these particulate exposures promote and augment a response to an infectious agent, and they may be tied to a genetic risk. So there's a kind of at least a unified theory attempt to incorporate how particulate exposure, infection, and genetic risk may all come together as causing or be involved with the cause of sarcoidosis. One problem is that there doesn't seem to be an obvious particulate exposure in many cases, and it would be a little difficult in and of itself for this model to totally explain all the organ involvement. So I thought this poster may be completely off base, but I really kind of liked it because it was at least another attempt at a unified theory. And this is the same group that was dealing with the heat shock protein and showing that it was much higher in sarcoid than TB. So these people went on, this is from Poland, to just postulate that persistent stimulation by microbial agents or particulates may cause a proliferation of T cells and sarcoid granulomas, and then there might be, and they use some examples of heat shock protein with mycobacteria and other things, and then there may be a cross-reactivity of the T cell with antigen on the basis of a sequence homology between the mycobacteria and the human or whatever, causing molecular mimicry and inducing an autoimmunity. And maybe heat shock protein's completely off base, but that's really not the point. I mean, I think it's the concept here that may be an initial exposure to something, that's causing some sort of cross-reactivity of the immune system, leading to what we call sarcoidosis. So this is what I, just thinking about the future, would maybe think that someone has to do, and this is the organization to do it, would be to develop, I would maybe postulate's the wrong word, but develop, or let's all agree on certain features that sarcoidosis has. And we could argue that these are right or wrong. I mean, I'll leave it up to WASOG or to us to figure out what we want to include in this. But these are things which I think are characteristic of sarcoid. And then what I would say is, let's then try to develop a unified theory which explains everything I just put on the last slide. We agree on what sarcoidosis has, what its constituents are, and then we try to come up with a unified theory. We don't have to think of it all at once. We can have people, brilliant people, much smarter than myself, working on the genetic aspects, the infectious aspects, the occupational aspects, but there needs to be some group or somebody kind of seeing how this fits into a big scheme. Someone's got to be there so to kind of put this all together. Someone has to be, I think, even though we kind of maybe all give up that we can't figure out the cause, someone has to be there kind of shepherding us back to, does this fit all the characteristics that we require sarcoidosis to have or not? And I think in the process of this, I think we need to examine the end organ compartment and cell trafficking and signaling. And I go back to a very interesting discussion that we had at the ATS in one of the poster sessions a few months ago, where actually it was Ulrich who said, and I totally agreed with him, said that, you know, we can't really look at sarcoid, you know, just looking at the blood. We have to look in the lung. We have to look in the target organ, and I think that's true. But then Elliot Krauser from Ohio State said, well, you know, the thing about it is that those cells that are in the blood, they're going to the lung. Something's signaling them to go there. And maybe there's even crosstalk coming back. And there may be eventually a way. There may be some other things in the blood that really can tell us about the end organ as well. So I think we need to look at cell trafficking, signaling, and maybe more compartments than the blood in the target organ. Maybe in the lymphatic system, per that poster of the lymphatics. I think we need to start also considering much more clearly, and I think Dave Moeller has gotten us to think about this, the chronicity of the exposure may be very important, and I think we haven't paid as much attention to that as we should. I think we need to further develop phenotypic descriptions of the disease and develop very tight, exact outcome measures to explore the disease further. So I just want to close with two things. Number one, I want to thank Marjolaine for an absolutely outstanding meeting that was, I think, you know, it's easy to say this meeting is the best meeting ever, but I've been to 5 WASOG meetings. I think it was the best one, I mean, personally. And I want to also just close by looking at this flag here, because I've been to 5, half of the WASOG meetings, only the last 5, and I never really looked at this flag very closely because it was usually hung up in a high rafter somewhere, and I came down and looked at it, and I looked at the 5 meetings I've been to and the 5 meetings before, and I noticed something, which is that I guess at the next meeting we'll put it down here. And then I'm thinking, well, I guess what happens to the meeting after that? Well, we're probably going to put it here, aren't we? I mean, and go down here. I mean, we could put it here for symmetry, but then when we get down to here, in 30 years, we're going to have to go here, and that's going to get everything out of whack. But I'm saying, what would Jerry James do? He might say, let's go over here, because we're going to cure sarcoidosis by here. We're not going to need any more meetings in 30 more years. So that's my last comment to you. I hope, even if we decide, which is the rational thing, to go down here, I hope, and I won't be around for this, but I hope that we don't go farther than here. I hope that we get to the cause and cure this disease. Thank you very much.